Well, thank you for having me today. It's wonderful to be here. I'm sorry I couldn't be there in person, um, but I'm glad I'm able to join remotely. Again, my name is Joe Unger. I'm at the Fred Hutch Cancer Center. I'm a health services researcher and statistician with the SWOG Cancer Research Network, and examining barriers and disparities in access to trials is one of my particular independent research areas. So thank you for having me. Next slide. Oop, there you go. Thank you. So I'm going to start at a very high 30,000 foot level as a health services researcher, just sort of talk about systems and then swoop down to the specifics very quickly. But here you can see that between the cancer population and the impact and diffusion of new treatments, there is this mediating research process, which is really a discovery process as it pertains to cancer clinical research. There's initial drug discovery and development. If a new agent or therapy is found to be promising, it advances to comparative clinical trials, where really the design, monitoring, and analysis of clinical trials has been refined over decades. But increasingly, as manifested by this, in part by this conference today, the idea of the representation of clinical trial cohorts is really seen as critical to the overall interpretation of trial findings, which then influence treatment decisions, whether at the public or private coverage level decisions or physician and patient level decisions, all of which goes together to impact the diffusion of new cancer treatments into clinical practice. Next slide. And this idea of clinical trials as a research process really came front and center to my mind when I was reading Cancer Moonshot several years ago, almost a decade now, which referred to the idea. I mean, I had been thinking about this from my own research perspective, but they really framed it for me that the Blue Ribbon panel recognized that accelerating progress against a disease as complicated as cancer really does require a more efficient research process. And so it's not just the individual trials we have to focus on, but the way trials are done writ large. Next slide. But as we all know, few adult cancer patients actually do participate in trials. I think the contemporary estimates are more around in line with the estimates of around 7 to 8%, but they used to be 1 to 2% or 3% decades ago. So there is, though, this large gap between the willingness to participate and actual participation, and of course it reflects the many barriers that patients face. So to understand the magnitude and types of barriers that patients experience, it really is critical to be able to view it from a framework perspective, because something that maybe is sometimes forgotten is that we can't do cancer clinical research without the patient's partnership. So we really do need to understand it in a very fine way. Next slide. This framework has highlighted some of my research, has sort of served as a platform for some of my research, and it really is, it's perhaps oversimplified, but I do think it's critical to understanding how patients sort of travel through the decision-making process as it pertains to cancer clinical trial participation. There will initially be a cancer clinic visit, at which point there is a determination about whether a trial is available. If a trial is available, then there will have to be a determination about whether the patient is actually eligible for the trial. And then and only then is there an opportunity for a physician to consider whether or not to offer the trial to the patient, at the end of which comes the patient, right? And so this is a long pathway, and I think it's often forgotten that between the initial diagnosis and the patient's opportunity to actually have some agency in trial decision making, there are a lot of hurdles in between them, between those, including the structural, clinical, and physician barriers. And all of this can vary and differ according to demographic, socioeconomic, and geographic factors. Next slide. Structural barriers are things like trial conduct necessitating a substantial institutional investment. So most of the time, and lots of times, there simply isn't a locally available trial. And of course, it's important to remind ourselves that most patients get their treatment in community practices rather than that large academic centers. So this is a particular issue outside of the academic centers. Even if a trial is available, patients are often ineligible because of comorbid conditions. Eligibility criteria are often aligned, but they play an important role in trying to protect patient safety, trying to define the experiment as well as possible, but increasingly regarded as being overly stringent. Excuse me. Physicians may prefer specific treatments, or they may have fear that the trial can interfere with the patient-physician relationship. And then lastly, of course, the primary concern for patients is finding the best treatment for their disease. But patients routinely express being fearful about being in an experiment or a corollary having their treatment assigned by a randomization, which is a sort of a mystifying idea to them. Next slide. So when we use this framework to interrogate, if you will, what are the magnitude of these barriers, it turned out, and what's the magnitude of these different barrier domains? It turned out that for more than half of patients, there simply isn't a trial that's locally available. And then for another nearly quarter, even if there is a trial available, they are ineligible. So the idea that we focus predominantly on patient barriers, in my view, has been, it's important because there is potentially a trial participation slot there when it comes to the patient. But if you really want to move the needle on trial participation, you're going to have to address these upstream factors. And it really does raise the question, okay, so what then if there are all these barriers between patients and trials, and we hear that so few patients go on to trials? Doesn't that beg the question, what is the participation rate for those who are actually offered a trial, which really is the more relevant question that we should ask as it pertains to patients' interest in clinical cancer research and contributing to that endeavor. Next slide. So we did a follow-up study where we examined just studies that actually characterized the extent to which patients actually agreed to participate in a trial if one is offered. This was a systematic review and meta-analysis and was mentioned by a prior speaker. And what we found was that a very surprising finding that if a trial is actually offered to a patient, they tend to participate more than half the time, 55%. And another really key finding was that there was no evidence that rates of agreement to participate differed by race or ethnicity. The rates actually trended highest for Hispanic patients and lowest for white patients. Next slide. So these results really did dramatically underscore the willingness of cancer patients to participate in a trial if one is actually offered to them. And it stands in stark contrast, the findings stand in stark contrast to the commonly cited statistic that only 5% of patients participate in trials. It's a statistic that really does fail to reflect the many structural and clinical hurdles that stand in the way of participation for patients. Next slide. Moreover, that study showed that Black, Hispanic, and Asian patients enrolled at rates at least as high as those of white patients, although they were all high, all more than 50%. And it suggests that observed racial and ethnic disparities in trial participation likely manifest earlier in treatment decision making in that pathway rather than at the patient level. And if you boil it down, it suggests that really a good way to improve enrollment of minority patients is to ensure that they're actually invited to participate. I've heard the term uh, bandied about benevolent bias. That is, there is sometimes argued that there is a sort of an assumption that certain groups of patients are just more distrustful than others and simply won't participate, and so a trial may not be offered. We have to protect ourselves against that assumption, however well-intentioned or otherwise it might be. Next slide. These issues really came to the fore, I think, in the literature when it with this publication by Laurie and colleagues in 2019. And what was different about this study was that it focused only on trials that led to new drug indications, whereas a lot of prior research um, that examined participation of Black patients in particular to trials had been at the level of the NCI-sponsored network groups and was frankly somewhat long in the tooth, and had been a lot of it had been done. The seminal studies had been done about 2 decades before, and what was so interesting here was that there was this finding of an especially egregious underrepresentation of Black patients, of only 3% of all enrollments among 230 studies that were examined. And the expected rate, given the cancers that were examined, was about 14%. So really extraordinary underrepresentation that was found there. Next slide. Now, we do know that trials supporting new drug applications to the FDA are primarily sponsored by pharmaceutical companies. And in fact, in that study sample that Laurie and colleagues looked at, 97% of those trials were industry sponsored. And I think it's important here to sort of tease out this difference by sponsors, because in point of fact, the NCI's sponsored trials and the network groups tend to examine questions that are more expansive and argued to be more relevant to patients. They will compare different treatment combinations. They will combine modalities. They will look at rare cancer studies more commonly, or things like non-inferiority designs or dose reduction type trials. And additionally, the NCI has had this sort of dedicated mission to bring trials to community and minority and underserved sites through their NCORE program. And in my view, this does represent a model to improve enrollment of diverse populations, is to get out of the side of the academic site primarily, and to better distribute access to trials where patients live. Next slide. I would add, importantly, that this estimate of 3% of patients being in trials who were Black was not actually something that rang accurate to me, because I exist within, I work with the SWOG Cancer Research Network. I've done a lot of research in this area over decades, and the rates seem to be higher to me. But it did become apparent that there maybe is a distinction between sponsor type. And in fact, in a follow-up study, and I collaborated with Laurie and colleagues on this study, we did a matched analysis where we matched cancers. We did an analysis looking at enrollments to SWOG trials, enrollments to those FDA pivotal trials, industry only, and we matched by cancer type and year. And what we found was that enrollment to the SWOG cancer trials was of Black patients was 3 times higher, 9%, compared to, again, to that 3% estimate from the industry trials. Still somewhat lower compared to 12% in the cancers we studied than what was expected, but much better than what was found in the industry trials. Next slide. So the FDA and the AACR examined ways to improve representation of Black patients in registration trials. This was back before the pandemic. they put together a workshop. In fact, the last time that I traveled before the pandemic was the ultimate insight visit, presentation of the findings from that, and there was a focus on myeloma. And they put out a white paper, and it really was an important white paper that actually influenced and the FDA guidance that was put out, and the draft guidance in 2022, indicating that sponsors must submit plans to help ensure the adequate participation of relevant underrepresented populations. I would add, now that guidance focused on race and ethnicity as pertained to diversity plans, but it also referenced other domains such as clinical factors, age and sex, as well as socioeconomic status, which brings me to my last topic of the day. Next slide. It's this slide is complicated, but if I could just walk you through it very briefly. The dark blue dots show the proportion of patients using Medicaid over time, and the dark blue line is a sort of a smooth regression line, giving the general trend. The light blue is the monthly national unemployment rate. And what is so fascinating to me about this pattern is you can see that the proportion of patients using Medicaid in clinical trials seems to track very closely with the monthly national unemployment rate. In fact, there's about a fairly consistent 1-year time lag. And it goes up and down as it pertains to important, economic events like recessions. In 2014, the ACA Medicaid expansion was implemented, and thus what is represented by those vertical lines showing all of the states that adopted the ACA Medicaid expansion. Shortly after this bolus of states adopted the ACA Medicaid expansion, what happened, remarkably, was that these lines were no longer converging, they began to flange, and in fact the proportion of patients using Medicaid diverged from the national unemployment rate. Next slide. So what do we infer from these findings? Well, first, the socioeconomic composition of clinical trial cohorts can be highly variable over time. That was clear as it pertained to those Medicaid proportions, but they actually were following a pattern. And in fact, the composition of clinical trials, if you take a step back, can be interpreted and recognized to be, in part, an organic manifestation of extant socioeconomic conditions. So it's not a fixed population necessarily. It represents organically what's going on in the population as it pertains to social and economic factors. I think this is a really important insight. What is also apparent from those findings is that targeted policies can act to counterbalance the potential adverse consequences of societal influences on trial composition, whether that pertains to things like providing patients better access to trials through Medicare changes to Medicaid, or potentially other interventions and policies. Next slide. So participation, just to sum up, participation in trials represents an opportunity to receive the newest treatments, as we all know. For patients, in my view, such a system should be free of the structural and patient barriers that have been routinely identified. It should be a level playing field. Such a system would also build greater confidence that trial findings are widely applicable and it would encourage more rapid uptake of new treatments in practice. Final slide, please. So how do we ensure diverse populations in clinical practice? I have a sort of a three-part recipe. First, ensure that trials are accessible to patients where they receive their care. Second, offer them the opportunity to participate in a trial. And third, provide the resources and support to do so. Thank you.